Okay, so we are continuing with our second speaker, Terje Andreas Eikemo, who is from Norway, and so that's why he will most likely be able to explain to us the Nordic paradox. So, first of all, welcome. We are really excited to have you. About Terje, he's professor of sociology at the Norwegian University of Science and Technology and the leader of CHAIN. CHAIN is the Center for Global Health Inequalities Research and brings together a multidisciplinary team of leading researchers with other stakeholders, like the UN system, for instance, in order to advance our understanding of health inequalities globally and to reduce the distance between research policy and practice. A great goal, I have to say. Terje is also one of the most distinguished researchers in the field of modern social epidemiology and has published extensively in a lot of different topics, like, for instance, educational inequalities in child mortality, or also a lot on inequalities in mortality. So he has led also many internationally funded public health projects and was awarded multiple prizes for his outstanding research. So Terje will talk today about the monitoring of health inequalities. And welcome, the floor is yours.
Thank you for having me. And I'll try to say this 10 times. It's a real zungenbrecher, isn't it? Yeah, thank you for the kind invitation. I've been looking forward to this for a very long time. Yeah, when I heard that the audience is filled up, also online, it's such a pleasure to be talking to such an audience. I also have to thank Michelle for her presentation. I mean, it was one of the best ones I've heard in a long time. So it can only get worse. So thank you for that. Yeah, and it's always good to come back to Germany. It's where I also studied in Leipzig a few years, some 20 years ago, and I studied Mittelhochdeutsch, and that was actually not so very difficult as a Norwegian, because the language is basically the same. So everyone thought I was brilliant, but I was just had a secret that no one was aware of. I was Norwegian, and I'm leading this center called CHAIN, which is based in Trondheim, which is the capital of the Vikings. But I can assure you, I come in peace. Of course, that's what the Vikings would tell you 1,000 years ago. And the CHAIN is a center that really aims to monitor, to explain, and also reduce health inequalities globally. And today I will tell you a bit about that work. I'm also the chief editor of the Scandinavian Journal of Public Health. So hopefully, did anyone submit to the? Not yet. Not yet. Soon, I hope. Let's see if this is the right one. To the computer. To the computer. Change. Aha. Who was asking that question? It was you. So actually, I took the liberty of adjusting the title just a little bit. You asked me to talk about monitoring of health inequities, but I'm going to talk about monitoring of health inequalities. And you heard the definition we just discussed a few minutes ago. One saying that basically inequities is what we can prevent. Those are the immutable inequalities, while inequalities are that we cannot really change. But at the same time, when we monitor, we don't really know if what we're measuring can be changed or not. And so here, I basically refer to being as neutral as possible, right? So not be biased in a measurement. So that is what I refer to here, not whether it's amenable or not, but we not be biased. That's the ideal. Of course, in real life, that's not the case. So usually when we in CHAIN talk about health inequalities, we refer to health inequities as the ambition and the aim. So this is a fight. We want to promote health equity, but we do that through measurements of health inequalities. To make things even more complicated, during presentations and everything, we tend to use the words a little bit interchangeably. That happens, of course, but we do have an answer to the question whenever it would appear. So we're aiming to monitor, explain, and reduce. And those are, of course, interconnected. We cannot explain without monitoring, And it's also difficult to conduct interventions if you don't know the explanation. So it's all kind of is interconnected. And it's a fight. I believe we are not only researchers. We are policymakers. We are change agents. We do this because we have a motivation to change the societies in which we live. For me, that's definitely the case. And it's a fight. This figure below kind of summarizes what we're doing. It shows the social gradient in child mortality by the level of maternal education. Of course, the social gradient is there from the 1985 to 2000. That's what you can see to the left. What you see to the right is actually the success in reducing child mortality worldwide. So it has been cut in half, basically, which is great news. But the social gradient is still there. So if you want to make further improvements, we need to address the gradient. And we need to start with children and the intergenerational transmission of health inequalities. Just to make sure that it's the monitoring part we're talking about. So why should we do this? I already partly addressed the question. So we want to inform explanations and we want to inform interventions. But then again, the magnitude of inequality would vary across contexts, across countries, across time, and we need to be aware of the, where the situation is most crucial. Where is it that we should intervene? And I think my interest really started back when I worked on my PhD. This is my first publication that I'm really, really proud of. And from 2008, when I used the European Social Survey. Anyone used the ESS before? It's a fantastic survey. Yeah, who used the ESS? Yeah, 3 persons. This one is from the 2 first round, and I tried to look at the magnitude of inequalities, like going up, relative inequalities. And then to the right, the total prevalence among those with less education. And I tried to cluster all the countries according to the welfare typology that they would be assigned to. So using Esping-Andersen typologies on the welfare state generosity and organization of transfers. Yeah, and basically finding these patterns. This is the Southern, this is the Central Eastern, Bismarckian, and the Nordic. And seeing these clusters is appearing like that. And that, of course, that made me curious that perhaps could this point to a direction where we can look at how countries are organizing themselves, their welfare systems, even their health systems, or is this culture, or is it both? This is all self-rated health, so it might be a cultural kind of deviations of or clusters of how we report. But they're also referring to relative differences. So you would have the same people in the same country as being the low and high educated. So still that would be kind of adjusted for these cultural variations, unless there are also biases across social groups in how we report. And Germany is here. And I remember when after this study was published, I got a lot of headlines in Norway, and they were not really, happy, all of them, because it really showed that the Bismarckian regime type fared better than the Nordic one. And then I had to explain that. Of course, I didn't have all the explanations, and perhaps I don't have them now, but it definitely kind of gave more rise to this Nordic paradox, really pointing at the fact that the health inequalities in Norway are larger than they should be, based on how our society is structured. Another way of looking at the importance of cross-national studies is this one that was published in which one was it? Did you get it? Was it PNAS, I think? Showing life expectancy, however it's defined, by income in Norway and the US. So Norway would then be the kind of a non-linear curve, showing that basically the social, if you're poor, or if you are definitely not rich, you should live in Norway. You would live longer. The system would protect you more than it would in the US. But if you're extremely rich, you should definitely live in the US. That's what it says. So whenever you make money, you should move around at a certain income level. Of course, that's one side of the story. The other side of the story is that there is indeed a social gradient, also in Norway, a country like Norway. So those in the longest income percentile would then have a net life expectancy of 74, less than that. And in the other end, you would get to 86. So 12. More than 12 years difference in life expectancy between the richest and poorest, even in a country like Norway. And these kind of results made us think about how we can think theoretically, conceptually about what are the mechanisms really linking the welfare state to population health, and that is what we try to do in this article. But I'm going to talk about monitoring, not so much about theories and explanations as I would like to. In Chain, we are trying to do all three things, monitoring, explaining, reducing, and to point back to the last speaker, we are indeed trying to do that in an intersectional way. We are focusing on children and the life course to the extent that it is possible. And geographical coverage is very important. Most researchers in the world are in this area are placed in Europe, perhaps even in the Nordic countries. The real problems are outside of our context, and that is something we need to be really aware of. And we also try really hard to translate our research into policy. And we have an organization in Brussels, EuroHealthNet, who is helping us doing that through making newsletters, fact sheets, and so we really try to be really aware. So we're doing a lot that I'm not going to talk about, like vaccine nationalism, climate change, One Health, technology. We look at we study effects of interventions, we look at cash transfers. But again, today I'm going to talk about the first part, the monitoring, how to really look at what is happening in Europe and the world. So today I'm going to show data sources, many of them upcoming. And the reason I'm here today is not only to present the research we do, I'm here to ask for your help. Because there is a lot of, we need more people to utilize the data sources we already have, and also to push forward to get the planned research infrastructures funded. So at least 3 or 4 occasions today, I'm going to ask for your help. So let's see how that goes. Also in some of my editorials, I've been really concerned about the need for new data that can really look into the causality, can look into the life course, can look at the effects of the digital world on children, pandemic. And we need to have biological data, we need to have social data from the family, from schools, we need to cover everything. And there is an upcoming data source, which I'm looking forward to discuss with you. Now, taking a step back again, looking at the first comprehensive cross-national study in Europe on this matter. I don't think there are others that can really compete with this one, also because it really sparked the whole research field. It's the reason I'm here. It's a study that was so shocking in Norway that government enabled funding to fund this research field. This is a study by Johan Mackenbach. Many of you might be aware of him and his group in Rotterdam. I was also trained in Rotterdam with Johan some years ago, and so part of the reason is also that I'm here is him. So I'm also thankful for all his guidance. But this published article in '97 really showed that the Nordic countries had the largest health inequalities in Europe. That was the conclusion. Of course, that these findings were controversial for not only because the results were disturbing, but also because it highlighted the need for being more careful in the measurement. So Johan and his group back then published only relative inequalities, right? Because if you look at the relative difference, it might not be the same as the absolute gap. And this study was really important to kind of, to also develop the methodological part of our field. So then Eriksen and Vågerø recently, or just shortly after, published this study, criticizing the study for we need also absolute measures. And that is what happened in Johan's next study in the New England Journal of Medicine. And the conclusion in that study was that variations are still there, both absolute and relative, and they are substantial. The pattern is not exactly the same as with the relative inequalities, but inequalities is still larger than it should be, and also in Nordic countries, providing more fuel for the Nordic paradox as such. And in this study, you also start finding explanations. So it's about income distribution, health-related behavior, and access to healthcare. This is the first study that I took part of with Johan in this group. And I really love this figure. It was never published. I don't understand why still, but I love to show it. And the reason is that it kind of shows a really nice way of presenting our results in a way that kind of captures both the relative distance and the absolute difference in the same figure. Can you see that? So the low, mid, and high educated, these are among men. This is mortality from 2000 to 2010. Still identifying Nordic countries as a problem area, I would say. Oh, wait, where's Germany? It's not there, isn't it? It's not there. That's the first thing I need your help with. Because, yeah, so here are the Muckenbach signature papers, and just an overview. I mean, there are more of them. So is there any news coming from Rotterdam? Well, yes, because this is where we have started a collaboration with Erasmus. It is the chain Erasmus data warehouse, where we are going to look at full population coverage, socioeconomic distribution of cause-specific mortality, and also all-cause mortality, of course, showing that we have a really nice coverage. The coordinator in Rotterdam, Wilma Nuselder, I reached out to her a couple of days ago asking, wait a minute, why is not Germany here? Is it because of lack of, is it too costly, lack of collaborators? And she said to me, well, I tried, but I simply don't think the data is there. Really? You cannot link mortality data with education in Germany? Are you completely, right? I mean, what do you do? This is for the next generation, right? This is the input you need for effective policymaking. How can you not have that opportunity? Is it data protection? Then I understand it to some degree. But we're researchers. We're doing it for the better society, and the results are also aggregated. So and you need to compare yourself to see how you are in European context. And these data they have been collected since the 1970s. So this is an opportunity to see how Germany is really faring. Monitoring the German development in health inequalities since the 1970s. At least you should start now. So I don't know what you can do, lobby or what? This is such a big country that is really needed. So going on from the European context to the global context, it is very difficult to do this globally, but we have to. I mean, I've been talking about Europe so far. So what can we do from a global perspective? If you think about the global burden of disease study, which you maybe not everyone has heard of, but definitely you have heard of it now. It's the largest collaboration in science. It's larger than CERN, as of particularly at least a couple of years ago when I was comparing them. So this is the largest systematic effort to map health inequalities worldwide, and they have. They're making estimates for like 11 age groups, men and women, since the 1990s, 204 countries, 500 regions, 90 risk factors, and 371 diseases, and 3,500 clinical outcomes. So this is a powerful tool. I mean, they are so powerful that governments are, I think, listening to the GBD. They are kind of preparing their health systems for the output that comes out biannually from the GBD study. And they have over 10,000 collaborators, certainly many in Germany. I think Germany has a color. That's good news. They must be around more than 50 collaborators in Germany, and it covers everywhere, all countries. So what we are doing with the GBD is to map socioeconomic inequality. So we are trying to integrate the social dimensions into the GBD study. And that is, I think, is going to be quite remarkable when this happens for the first time. Socioeconomic factors as risk factors. The social status is that a risk factor? Should I be treated as a risk factor? Not perhaps in sociological journals, but definitely if we want to make a change in the real world, you have to speak in a language that is spoken worldwide. In the prevention area, even if you want to do promotion. So I think that getting education now as the first risk factor into the GBD study will be a major step forward, where we can finally compare the significance of the social world towards all other risk factors that are included in GBD. I hope this happens in 12 months, but more realistically, perhaps a bit later. But we are on the way, and this is the first step. We were able, through a systematic review, to identify a universal association between parental education and child mortality. And this is the first paper. So the estimates from this article will then be imputed into the GBD study at some point when we have enough evidence ready to be imputed, so to speak. And what we did was that we basically looked for studies everywhere. So these are all studies published last 4 years on the association between child mortality and parental education, where we had no data, or when we had access to data, such as the DHS survey, the Demographic and Health Survey, we used those sources or in combination with published literature. So this is basically 3 million deaths, 300 studies, this is not so readable, but at least you can look through the slides later on, showing the confounders that were identified in all these studies. So in doing this, you can say that more than 40% of the studies adjusted for age, wealth was adjusted for in 10% and so forth. So this is a way of seeing kind of what are the confounders, what is kind of driving the differences, but why is education important? Why is parental education important? And it is important. We found that reduction in under 5 mortality, comparing mothers with 12 years and no education, reduces the risk of 31% of the child dying the first 5 years. And for fathers, this association is 17%. So this study also showed that fathers are important, and that is a really important finding. These findings were, we see these findings as in a period where we also have really small children. So it was just like, it felt so when this came out. So it's a study that is really close to our hearts in the team. We also showed that the importance of education is increasing as the child gets older. So biology perhaps is more important in the beginning, and then the social work starts to take over. It doesn't really matter where you live in the world. The association is the same, or at least a different way of saying it is that despite having all the evidence in the world on this association, we cannot find a difference. And this is the next study. This is the next one, and this is insane. I wanted to say that, and I said it. The study, because we think it is the largest meta-analysis ever conducted. But if anyone did a larger one, let me know. And it's a competition. 558 studies extracted. So we started off with 15,000 studies. So we had a team of 5 to 10 researchers working 3 years. The data availability here is a bit skewed, as you can see. So the value of this study is also not only in finding this association, as I will show you, but showing the data gaps. So monitoring is also about monitoring data availability, not just the associations. So most of the data that our study relies on are from the global north. And here is an overview of the confounders. High-income countries, more to the right. Most studies controlled for sex and age. And also you can see that, for example, in the Latin and the Caribbean area, you might have confounders pointing more at like urban residents, right? So you can also have get a feeling of what is important where. But in a meta-analysis, we cannot include all confounders because not all studies have everything. But this is a really nice way of also monitoring explanations or intermediate factors. And this is to show that the more socioeconomic advanced a country is in terms of education, fertility, income, which the SDI index consists of, the more data availability, right? So there's this kind of unbalance. And here are results. We find that there is an average reduction in mortality risk of 1.9% per additional year of education, which is the same for all regions, or not a difference between regions. We also find even an effect for among those 70 and more, and no difference between level of social demographic index. And this study is still in the review, so we'll see what happens. We got some criticism the jury is still out, but hopefully this will come out soon. Okay, so now I'm talking about the Europe, mapping in Europe, mapping globally. I'm going to talk more specifically about COVID. So we are leading the UN WHO Technical Advisory Group's work on estimating the impact of inequality on COVID-19 mortality. Don't ask me to repeat that. We're basically trying to find out what inequality means for survival and death of COVID-19. And in this article, we basically tell the world's community in a WHO bulletin what we are going to do. And we also ask for help, because we cannot do this alone. We can use machines, but if we can use people, it would be much better. And we got response. So today we have around 30 researchers working regularly with us on this review from all parts of the world using their research time. So if anyone is listening to me now, so thank you so much. The objective is really to make an overview of the theoretical landscape of frameworks, but also to quantitatively synthesize the effect size. And the number of studies, so if 600 studies was the largest meta-analysis ever conducted, then I'm trying to point, so I have to do this. And also heard that this is moving, right?
You're out of it. Now you're back.
Sorry for messing up the, 1,000 studies, almost. And these 1,000 studies are distributed as follows. Again, this is something you can look into afterwards, but we have made this, these are all the dimensions that the kind of inequality world has taken into consideration when analyzing COVID mortality. Ethnicity, sex inequalities, geographical inequalities, wealth, work, education, but also everything else. We have started off, and so these are the total number of studies. Look at the shadow, that's very effective, we can do like this, but I can't put that 401, showing how many studies we are now extracting information from. So if anyone here is interested in writing up a paper as part of the WHO UN tag, let me know. We have already identified the studies, we are doing the, yes. So help us. This is the second time I ask for help. And it's a good way to get affiliated with Jane's work, but also with the UN organization and the WHO. We have started off with education already and ethnicity, but if you want to look at any other dimension, let us know. Okay, zooming back in again, less mortality. I mean, talking about death all along. And here he is.
Give me a moment. I'm sorry for interrupting
the
speech, but this is like crazy.
This is crazy. So this is not crazy. This is subjective measures of health. And European Social Survey. I guess there were 2 or 3 or 4 of you have used it already. And this is going to be a data source you're going to use, I can promise you, because what you can do now, this is the 3rd time I'm asking for your help. Use this data source, use it, and take part of our special issues and so forth. The European Social Survey is the social survey in the world, in Europe, that has the highest kind of, I wouldn't say high, probably there are people here from SHARE, from EHS, from other surveys. It's a very good survey. I would say the best, but it's, I'm biased. It's like equity and inequality. Because in the ESS, you can apply for your own questions, getting your own questions modules into the ESS, and basically have your questions being asked to 100,000 people. And we did that successfully in 2014, and again now in 2023. So can you imagine? We have now a possibility of see how the social determinants have changed since 2014 through the pandemic and until now, and really teasing out the value of welfare systems and countries. And here's the team, Claire Bambra, Tim Houts, Christian, Mirza, and myself. Mirza is coordinating this whole effort. These are kind of studies you can do with the ESS, just showing like simple prevalences, showing that Germany has larger inequalities than Norway in 2014. So since we are just talking about monitoring, not so much explanations, and just showing simple prevalences, these are probably age-adjusted, I would assume. But then what you can do with these studies. So this is from the ESS 7. So we have then kind of imputed in an already existing sociological survey, like medical questions, lifestyle questions, like NCDs. And by bringing medicine into social science, we're actually trying to, what we really want to do is bring social science into medicine. So by kind of merging lifestyle factors with everything else, which is already present in the ESS, like social stratification variables, you can do a lot. So we have for behavioral determinants, smoking, alcohol, physical activity, and fruit and vegetable consumption, like the big four. Material determinants, like financial strain, income level, housing condition. We have occupational determinants, healthcare access. I'm particularly fascinated by unpaid care, which is a really important one. And just think about how unpaid care might have differed since 2014 until today. And then also psychosocial determinants, which in the last module in 2014 was a bit under prioritized. So in the update, we have actually added more psychosocial determinants. So here we have added sense of control for the psychosocial determinants. And what I have highlighted in the other measures there is just that we have improved the measures, that the questions can still be compared. So then think about what has happened since 2014 and 24. This is a remarkable source of evidence. And what we can do is to give the final answer, maybe, to the Nordic paradox. I think, or we think, that one reason why the paradox is there is because the Nordic system has not really been put to a real test, right? So the pandemic could have been the first real test of the system to see how it has kind of mitigated the inequality measures through the pandemic in a different way than other countries. We can compare, like, of course, the effect of lockdowns and so forth, maybe, even though we didn't ask those questions. But a systemic response, I mean, but definitely we can look at many other determinants. So here's a list of all the NCDs that are present in this study. So if you're interested in any of these like outcomes, they're both like physical, mental health. You can really look through the whole period and look at the development. So what you could do, for example, is to compare lifestyles, occupation, living conditions, and see how much that explains of the health inequalities in Europe, right? So although I am not talking about explanations today, this is just an example. So in a country like Norway, actually behaviors are the main drivers, because behaviors are mostly unequal distributed in Norway. It doesn't mean that the other determinants are not important. It means just that the living conditions and occupational conditions are more equally distributed in Norway. So behaviors stand out. While in Germany, it seems to be both occupation and behaviors, while living conditions do not contribute so much to explain inequalities. It could be because living conditions indeed are more equally distributed. Just an example of what you can do. So have a look also at the supplement we published in the European Journal of Public Health a few years ago. We want to repeat this now with a new module. And this is a design study that you also can look at. And when you use data that is funded by the European Commission, they're really interested in hearing about your results. So this is another good reason for using the ESS and other surveys that are covered by the Commission. So I think 3 times we were invited to the Commissioner of Health to present on health inequalities. COVID, young people, mental health. 3 keywords that are really of concern of mine and should be for all of you. This study shows that mental well-being worsened among adolescents during COVID-19. It's a meta-study. Also in the Scandinavian Journal of Public Health, I've published already 4 special issues. The next one is coming out next month, actually. What I've seen in the submissions so far is that the impact of the COVID-19 pandemic on mental health care in Norway is like this. So the primary care visits increased rapidly right after March 2020. According to mental symptoms, anxiety, depression, ADHD, sleep disorders, also specialized care show a similar pattern. The authors conclude that the findings suggest a worsening of mental health among adolescents, and that a larger deterioration might be seen in countries where social restrictions were more profound. I'm also receiving studies from Sweden that typically conclude like this. This may be explained by the Swedish authorities' decision to keep schools open to this age group. They didn't find an impact in Sweden. And another study with the same conclusion. Keeping life as normal as possible could be one important factor in explaining this. So just like too rich and wealthy countries like Sweden and Norway show these differences. I'm not concluding which country did the best or did the worst, but this is what I see so far. The studies that were sent in are not directly comparable, but there is a pattern in the conclusions that I can really say, and that shows again why cross-national studies are important. If we look at duration of school closures worldwide, it was worse than in our part of the world. So if it even had an effect in Norway, you can imagine the health deterioration we've seen elsewhere in the world. And what we try to do now in collaboration with UNESCO chair of Global Health and Education is to see what it has meant for children around the world during lockdown, and to be part of also safe openings of schools. So we have asked thousands of health professionals and teachers about how they have experienced the period and the children that they teach every day. So this is actually a qualitative survey. It is not a quantitative mainly. So this is or a mixed methods, I might say. Again, pointing to so Norway and Germany are two of it's the best place to live on earth if you're a child in terms of social and education and health policies. But even in a country like Norway, you would find these disturbing patterns. So what can we do about this? And this is where data availability needs to become better. So more evidence is needed, and particularly on how the digital world and COVID, this toxic mix, is affecting children. We don't know this, but of course the complexity of the reality cannot be completely matched with the complexity of the data. But we can get closer, and I just added this last sentence today. We can get really close, really close. And this is the fourth and perhaps last time I'm going to ask for your assistance today, and that is to support this study, which is going to be the first European-wide longitudinal study of children. This is a study that really has children as the main focus. We really owe to them that we are focusing on them now. They don't have any. That they cannot vote. So they didn't decide whether to stay in school or not, or what to do during COVID. We had to decide that for them. This is a time when we can decide that we offer them this chance to get the evidence needed over the next decades to see what the consequences have been. Not just of COVID, but the whole social world they're part of, including the use of digital devices. So it is going to be a survey that is of high quality. It's Europe's only longitudinal cohort study, and it's going to have an accelerated cohort design, meaning starting with a cohort of age 8 in 2027, and infant cohort age 9 months in 2029. In a country like Germany, I would expect a sample of 10,000 of each of these cohorts, and they have to be, and they will be followed up until 2053. It will cost 800 million euros, and Chain's job in this is to secure funding in Norway. Now you have to secure funding in your own countries for this study. That's what I'm asking you, and to start lobbying. Get more information about GUIDE. It's coordinated by Jennifer Simmons in Dublin, and also coordinated by Gary Pollock at the University of Manchester. So can we do this? Can we flatten out the gradient? That's yes and no, right? If we look at monitoring, we can also monitor like changes. If we can assume like counterfactuals, what would happen if everyone would have higher education? What would happen if everyone would behave in the same way, and as those with the highest education? Or as you mentioned, you might have heard, I focus a lot on education today, but that's not the only stratifier we're interested in. But it's to get some synergy in my presentation. We can also get our research into policy documents. The UNICEF report card series is a valuable source of information that I would really encourage you to look into. And we are collaborating with Guido Ruiz and his team at UNICEF in Innocenti. This report was on places and spaces on how the environment affects children. So here the focus is on children. And I think that that is a really important area to focus on. Another area of where we focus on children, here's an example of Chain's intervention area. Here, our team went to the Greek refugee camp, Mavrovoni, which basically is the camp that took over from Moria, that burned. And this is an old military camp, and we were concerned about about the toxins in the soil where children were playing. So one of our researchers, Karin Brubak, she smuggled soil samples. So this is what I mean with actionable research, right? Getting your hands dirty. And we analyzed the samples in Norway, found seriously high toxic levels. And our university, they got really nervous about the implications of these results. Getting the Greek government or the commission or attacking us, but surprisingly the opposite happened. So nothing happened. So this has been out for a year, nothing, silence. And I think this sadly resembles a little bit what I've been talking about. So who is in power? And children are the most powerless, right? And it just kind of confirms what I've been talking about earlier on. And we need to change this. Yeah, I'm not sure why I'm showing this picture again. I think it just ended up there, where we are at the European Commission talking about the results of the European Social Survey. I have no idea why it's there, but now you can see our faces again. And also the gender imbalance was not the point of my. Okay, let's move on. But we can also recommend, right? We can here. I was part of the Norwegian expert group. We provided 29 recommendations to combat social inequalities in health. These recommendations can also be applicable to other countries. Here are areas we have suggested, particularly focus on the life course, starting early education. A few years later, the expert group was actually dissolved. So that was another kind of mistake, I think, in Norway. We should keep an expert. All countries should have an expert group going on that informs the government. Do you have an expert group in Germany on health inequalities? Perhaps I have to ask a fifth time for help. That's something you can think of. And we are also. Yes, we are. This is another slide that kind of is slightly misplaced, but we're working on interventions. And anyone here was involved in a JAHI project? Yes. So this is a project that really collected all the actions in Europe that were to see what helps to reduce health inequalities, concrete actions, and 79 of them. And we evaluated the whole action, the whole program. I think we evaluated the program really positively, and some countries have come really far in the actionable approach towards reducing health inequalities. Yes, we have an annual report you can read in. Here are some of our partners listed, but since we started, we have more partners. Sorry, my phone was ringing. Is my wife in my head to take it? It was my son. He has his last day in school today, so he probably wants to visit some friends. This is Shane, and reach out if there's anything. I hope you have taken notes of all the help I've been asking for. And I have no idea where they kept the time. My strategy was to compile a lot of slides together and hope for the best. And I hope that, yes. Okay, thank you. It's calling in
yet. Thank you so much, Terje. Do you need to? No, you don't need to take the call.
No, I don't. Turning it off.
Okay, I already see there are some questions in the room.
Yeah. Thank you. My name is Saar Chemali, and thank you so much for the resources you shared and all the work on the data. And you also mentioned there's a lot of recommendation has been done and reports. And I would like to ask if there is a concrete example, if any of these recommendations have been really picked up on a policy level, as part of your experience so far. Thank you so much.
Yeah, that's a notorious, is an excellent question, and I get it a lot, and sadly, it is very difficult to monitor policy changes based on research, because you really don't know. Even if there is a policy change, you really don't know from where was the source of that change. Very often it's a change of government. But what I think is a good strategy is to keep the messages simple and repeat them. And in Norway, for example, my main action point is to bring free school meals into schools, because I think the schools are so important, because they are it's a place where you can break the pattern of the reproduction of health inequalities through generations. In Norway, you have to bring your own food to schools, of course, this will result in the fact that the more wealthiest families will give their children a better, more healthy, or food at all, right? This has now become a case for the new government. It's not new any longer that they want to promote this. I have no idea if our repeated messages was part of it. We can hope for it, but it doesn't really matter. If it's done, it's fine. Yeah, but if we look at more the interventions on the ground, like we did in Greece, if they would have come after us, that would be something valuable. But I think this is the problem of our research and the translation part. What is really picked up? In the end, it's we cannot stop in working on it. I think if we would, then definitely that would have a negative consequence. That I can say. So we just need to keep pushing.
Thank you. Other questions? Maybe
no difficult one, not like the difficulty level that you got, please. No life expectancy, no.
Well, you already covered that.
Yeah, yes, my God.
Navina, I think there's a question in the chat.
Yes, there's a question in the chat. Thank you, Terje. Question. Monitoring seems to focus on absolute measures like differences in life expectancy. Considering that equity is relational, do you think that an index of health inequalities, like the Gini index for income inequality, would be helpful to document trends over time?
Yes, it is very useful. I showed another index today, the SDI, which is a combination of education, fertility, and income. The main problem with the indices is that it is sometimes difficult to capture the main mechanisms because they are compiled of different measures. So you cannot really. So if you see that there is a correlation, then you have to go back. But what part of it was it? Education? Was it income? What was it? Right. So I think, but they're also useful because they show some sort of a general level of poverty, maybe that can change the focus to an area. And the main advantage of using them is that when there is a lack of individual level information within countries, we need to look across countries and look at country level measures. So definitely the Gini index is a very popular measure and should still be used. But as much as we can, try to make an index both comprehensive but also comprehensible, so that we know what is really measuring, and also that is policy translatable, because sometimes they can be really fuzzy and you don't really know really what it means. Like my research today, I'm showing the additional factor 1 year of every education. What does that really mean? So kind of having a translate. Yeah, I'm talking myself away and throwing away, and let's.
We still got some time.
Yeah.
It's completely.
Yes, and I think we need to ask that guy again to come back probably and then fix the pointer.
Okay.
But I can.
No, thank you.
You got a bit shocked now with my. Yes, I shocked.
Yeah. We had the opportunity to meet before, so.
Yes.
Okay, so but there are more questions,
Yeah, more questions.
Noticing right now,
Yeah.
there's the question up there.
Yes, here it is. I want to second the thank you for introducing us to the multiple data sources available on the topics that you introduced. But you also mentioned the data being quite biased towards high-income countries. And what I would like to hear your opinion about is what is actually needed to fill these data gaps? Because I think they're actually tremendous, and it is difficult to work with data that is, well, just to can repeat that, kind of biased, and would need more of those data, especially from sub-Saharan African countries.
There are some really good collaborations, cohort studies around the world, also in the Global South. And I think we need more of cross-national collaboration. We should also be very careful that what we think is needed I think maybe the audience here, might not be like the best strategy everywhere. So kind of imputing our knowledge to another world, that's something also kind of, it has to be an initiative that also, comes from a country like Germany, where you don't have, you're not linking education to mortality. So it also have to, I'm not sure, how do you feel about me coming here and tell you how to collect your data? That might be, if you multiply that by 100, then you might think, how it would be for me to go somewhere else in Global South and say the same. So it has to be done, with in a careful, considered way, with the best intentions. But we need the data, but it has to be collected and monitored and used in every country. But I will really speak the case for cross-national collaborations, cohorts, like the Global Burden of Disease study, for example. They are really influential in this area and is helping us fill this gap. It is also possible to interpolate, right? So you can assume a distribution based on a neighboring country, but that's not an ideal way to do it. But that's how the Global Burden of Disease study can cover 204 countries.
Thank you. Any more questions from the chat or? I think, so the chat, the people online can hear you. We need the microphone. Thank you.
I didn't introduce myself before, so I'm Jeff McCaskey from the HPI Institute. Obviously, the work you've cited of Chris Murray and company is brilliant. It has its limitations, as Chris noted in his editorial, but it's great. And the DHS surveys, which are a principal source of population. But you didn't mention anything about the in-depth network and the demographic health and surveillance
One
sites.
of networks, I was, when I mentioned these networks, I was thinking particularly about that one, actually.
Because it's a very rich source of very textured, detailed information.
What's the access? How can it be accessed? That's,
Through the in-depth network. And then the individual sites can make agreements, whether it's in Nigeria, Tanzania, Uganda, or wherever it might be, to be involved with different kinds of things. So we work on malaria prophylaxis, on other kinds of specific conditions, but there's also an underlying essential events kind of monitoring and tracking, and there's a way to get into that. So I can put you in touch with the in-depth network if you'd like.
Yes.
Okay, we'll touch base after.
Well, thank you so much for connecting here.
It's worth quite alone.
Perfect. Any other questions? There's a question right there.
I didn't say I was. Andrew Farley, University of Oxford. Fantastic talk. It's wonderful. All this material has incredible implications for the way in which we manage health across societies. And I'm just thinking from the UK, NHS, it's highly pharmaceuticalized. It's hospitals, you fix problems with all this kind of stuff. If you could sort of have a vision 20, 30 years time, how we would do health differently. I mean, it's paradoxical because we're working hard to get universal health coverage, the minimal thing. And if you look at the US data, a lot of that inequality is actually lack of access to health care in the bottom 20 or 30% who don't have health insurance. But this does sort of say that we're doing a lot of things in a weird way and that we should be doing it very, very differently. I wondered if you could play with that idea.
Please have another hour. This is something that I was at the University of Oxford a couple of weeks ago, and we were discussing just this, the sociology in that field. Oh my God, for the group, it's so great. So inspiring. The title of my lecture back then was "Bringing Social Science into Public Health," and I think that's one way to go. So look at this. So keeping a track on education is basically to invest in education, quality of education, as a means of promoting health instead of thinking here and now, which is very often tempting because you can really measure and monitor what's happening here and now, just like during lockdowns, and what kind of systems are in power at every time. So we need to get the social systems more upfront and get them in power. The power is so important, and it's a systemic problem. But getting the education into the GBD study, I think, is it's going to be a huge step. It's going to kind of visualize what education means for global health as compared to 90 other risks. So we need to be pragmatic and think about the lack of education as a risk factor, although I don't really like the way of phrasing this, and also adjusting our talks to the audience. Perhaps I would have, yeah, okay.
Thank you. Yeah, I mean, I'm sure you could add a lot onto this.
No,
so
that
maybe
was
we
all.
can
I have
talk about
nothing
that.
more.
Yeah.
That was
No, nothing more. Well, there are two more questions, so I think let's see what they are.
Thank you. Listening to the two talks now, I think for some in the audience as well, there comes the idea, okay, but we know all this. Like there is a lot of data and a lot of new data and a lot of monitoring added and more data will be generated. And it's not always new knowledge. But the knowledge policy gap is also nothing new. Like there would be also so much knowledge, but the policy is not changing. And that leads to a lot of resignation. No? So I understand that from your center, you are saying you do the monitoring and then you also aim to reduce. I think it's a very theoretical or visionary question, but how much do we really need to collect new data and how much do we need to work on the data that we're already having?
We can stop and see how it goes, right? We can ignore it and think, we already know this, so let's just stop doing this kind of research because that's something we know. And then let's see in 10 years what happens. I think what would happen is that we would kind of we would miss the link to the problem. We wouldn't see the problem because this is a problem that can only mainly be seen in social science. You might see it on the street, you might when you meet people, but the social gradient cannot be seen.
Yeah.
So
or maybe
well, if we talk about new evidence, we didn't know until a year ago that there is a universal association between education. I was just showing you the study and child mortality. It doesn't matter where you live in the world, if it's Scandinavia or Germany, the association is the same. The mechanisms differ. It just means that the education is an area of investment. The second reason why we need more data is because we don't know the harms we have done to our children.
Yeah, I have another idea. Maybe we need to change the way we do research. Maybe if we actually see we want to, we have the moral imperative, like Michelle also said, that we already know what's right and what's wrong, but we're still, with the way we do research, we see very few change happening. But there are ways of research that actually directly target societal change. And from the two presentations so far, that was also I don't know how my colleague in the back was discussing what kind of research we do and how that actually doesn't grasp the complexities of the topic, but also it doesn't grasp the changing the society and changing the current system.
I think what you're asking is not, we need a diversity of methods. That's what you're saying. We need diversity of data and the way we need. So one example is, so what's the role of technological advances? We live in a society where we're not only limited, but there are also opportunities everywhere. So what about the new technologies that are produced and who are they given to? What kind of decision-making processes are currently happening at hospitals? Who are getting the most recent technologies? So what we've seen is that the doctors start discussing the education of the patients. They're discussing, their literacy, right? So getting into these decision-making processes and is one way of getting that knowledge. But I think it's a very, very no. I hope you don't mean that you're saying that we don't need more data. We just now we know, and let's do something about it. I think that we continuously need to push governments and organizations and to visualize to the extent that it really comes close to the reality of what is going on. We can never stop. But I take your question as a more as a kind of debative one. No, it's not. You don't want more data. Okay, then we disagree. Yeah. Okay, then fine. I'm sure we can agree.
Thank you. And I just wanted to add, I mean, we asked you very specifically to show one part of your research, and there's so much more.
This is monitoring. Yes, this is. I was not asked to talk about interventions and explanations and mechanisms and theories. That was the monitoring part.
Exactly, and we will also cover intersectionality and also participatory health research, which is probably something you're also hinting at later on. So different approaches that also need attention. There are two more questions. One in the chat and one, Jeffrey, can you raise your hand? So, yeah, okay, thank you. Chat first, please.
Okay, I think you're successful in asking for help. There's a question in the chat by Julia Pantolo. She's asking, where can we find your list of projects you're looking for support and further research?
Yeah. Maybe after the conference, I could send you the information that could be sent around. And of course, and check your spam, because obviously I ended there somewhere today, and then you can ignore it or not.
Okay, so just get in touch with us or directly with you.
Yeah, you get in touch directly. It's possible also. If my information is out there. So.
Yeah. Thank you. And Jeffrey?
I don't have a question. It's more an attempt at answering the paradox of the woman sitting behind me. I worked for 26 years here at the local level in this district where we're sitting, doing health reporting. I often used cut and paste for recommendations that I made 20 years ago and brought them into new reports. I always tried to find the best data that was possible. And I thank you for pointing out the problems that you have with data protection that doesn't do anything about Google, but does affect the use of public data for health reporting. But I can report a success. My colleague, who has also been working for 20-some years doing health promotion in our district, was able to, for the first time in the time that we were there, get, I think it was $150,000 for health reporting that dealt with problems that he could show that the problems existed on hand. The problem, he could use research to show that the problems existed, and he could use our data, my data, to show that the problem existed in this and that neighborhood. And at the local level, you actually have the chance of doing things, at least for the people who are living there, if you can show that this problem exists there. And if people always told us, well, we don't need to do this, we don't need to show the problem, it's been done in the literature for 20 years, but if you can show that the problem exists for the children the children of the people who make the decisions, you can get some change, you can get resources, you can actually accomplish something for better health.
Thank you, Jeffrey, for that comment. And thank you so much, Terje, for your talk, for answering the questions, and also for asking for concrete support and help.
Thank you.
We will be in touch with you.
And thank you for your attention, and yeah, thank you for letting me be here and talk to you. I'm really grateful. Hope to come back someday. Now you can applaud.
Thank you.